Hello, good afternoon, everybody. Hope so everyone is okay there. Okay, today's our topic is actually very important topic, that is complication of PIH and management of PIH. Okay, hope so on Saturday, you know everyone the lecture on there is an introduction, then pathophysiology, etiology, then investigation. All this part is covered. Hope so. But in short, we will go for the just a revision. Okay, so in exam point of view, this is very important lecture. Actually, you can get a long question on this topic, or you can get a short note also. There can be a long question. There is always a combination of the long question has always a combination, which may include definition of PIH, enumerate the complications of the PIH, then management of the PIH. Okay, like that. There is a this is very important topic. In practical also, examiner can directly ask what are the complications, enumerate the complications. He may ask different pathophysiology of the any complications, right? Is it okay? I'm audible? Siddhant? You're audible. Right, okay. So let's have some introduction regarding PIH. Okay, so the PIH is a pregnancy-induced hypertension, which is a multi-system disorder. Okay, so where the blood pressure is more than 150/90, and which is associated with proteinuria, we say it is a preeclampsia, right? So actually, it is very common. It is very common in primary patients, primary gravida patients. 5 to 10% of the pregnant patient has a PIH. I repeat, 5 to 10% of pregnant patient has a pregnancy-induced hypertension. And you know the overall mortality of the pregnant woman, 16%, 16% mortality is because of pregnancy-induced hypertension and complications of the pregnancy-induced hypertension, right? So the already you know there are the classification, which includes there are 4 types which is defined. One is the important is the preeclampsia and eclampsia. This is one complication, preeclampsia and eclampsia. Second one is the chronic hypertension. The patient is known of the hypertension, chronic hypertension, right? The first one is the preeclampsia, eclampsia. Second one is the chronic hypertension. Third one is the preeclampsia superimposed over chronic hypertension. Third one is the preeclampsia superimposed over the chronic hypertension, right? And the fourth important one is the gestational hypertension. Gestational hypertension. Okay, what is the difference between all this classification? Gestational hypertension means the hypertension which occur first time during this pregnancy, mostly after 20 weeks of the pregnancy. I repeat, when the hypertension or blood pressure more than 140/90 occur first time after 20 weeks of the pregnancy. Okay, and which is not associated with proteinuria. And this hypertension subsides 12 weeks after the delivery. Okay, in some books I think mention is the 6 weeks, but in standard textbook it is mentioned that it is subsides after the 12 weeks of pregnancy. So the 4 types classification: preeclampsia and its complication. Second one is the chronic hypertension, which is since long, patient is having since long, that is a chronic hypertension. Third one, preeclampsia superimposed over chronic hypertension, right? And the fourth one is the gestational hypertension. Okay, so the gestational hypertension is important. Anyone can ask the definition. What is the definition of gestational hypertension? That is the hypertension which occurs first time during the pregnancy after 20 weeks of the pregnancy, and which is not associated with proteinuria, and which subsides after the 12 weeks of the pregnancy. Okay, so you can have a short note on the gestational hypertension or the classification of the preeclampsia also. Okay, so what is the pathophysiology? You know, the pathophysiology means it is a systemic disorder, means every organ of the body is going to involve in this condition. Okay, what is the reason? There is some problem into the placenta. There is a problem into the placenta, that is a trophoblastic invasive problem is there, and because of that something is wrong, and there is a systemic vasospasm. I mean, all the microvascular structures undergoes the spasm. That is a systemic vasospasm. That is very important part of the pathophysiology. Second one, the endothelial lining of the vessels has an endothelial lining. You know, there is a damage to their lining, that is called as the that is also part of the pathophysiology. And third one is there is an imbalance between different factors, pressure factors. There are some prostaglandin which favors the vasospasm. There are some prostaglandin which favors the vasodilatation. So when there is an imbalance between that prostaglandins, it is also part of this pathophysiology. Right? This is in short about this introduction. Okay, just have again revision. So the incidence of, I already said, incidence of the PIH is around 5 to 10% of all the pregnant women, around 5 to 10%. This is, you have MCQ on this. 16% deaths in maternal or in pregnant women is because of hypertensive disorders. Right. Definition: it is a multi-system disorder when the blood pressure is more than 140/90 mmHg after the 20 weeks of the pregnancy, in previously normotensive or previously non-proteinuric patients, and it is called as the preeclampsia. Okay, so the multi-system disorder, it is an important point. And there is one more entity, that is the delta hypertension. This can be asked into the exam in your viva. Okay, what do you mean by the delta hypertension? Delta hypertension means when the patient's blood pressure suddenly rises, like the patient's blood pressure suddenly rises, in which systolic pressure if rises by 30 and the diastolic pressure if it is rises by 15 millimeter of the mercury, but which is less than 140 and 90. So we find the range is in normal only, but there is a sudden rise into the hypertension. There is a sudden rise into the blood pressure in systolic by 30 and in diastolic by 15 mm. But the overall blood pressure is less than 140/90, right? So this patient is also has a complication like preeclampsia. But the blood pressure, the final blood pressure is always less than 140/90. But when there is a sudden rise into the blood pressure, which is also problematic, and that is called as delta hypertension. Okay, so the delta hypertension, it is a hypertension, the range in which sudden rise in the blood pressure, 30 in the systolic, 15 into diastolic, but overall blood pressure is less than 140/90. But we can say this is a dangerous patient also. Okay, so that is a delta hypertension, right? Just remember this word, delta hypertension. Okay, so classification we just discussed: preeclampsia, eclampsia. Second one is the chronic hypertension of any etiology. Then preeclampsia superimpose on chronic hypertension, and fourth one is the gestational hypertension, right? So this is important, classification of the preeclampsia. So then again in books there is a mention of severe preeclampsia and mild preeclampsia. The mild preeclampsia is also called as a non-severe preeclampsia. There is no entity, there is no word of moderate preeclampsia. Either it is a severe preeclampsia or a mild preeclampsia. Mild also called as the non-severe preeclampsia. This can be asked in exam also. Just remember this: mild preeclampsia or severe preeclampsia, right? So these are the characteristics, or what are the presentation of the severe preeclampsia: when the systolic blood pressure is more than 160, when the diastolic blood pressure is more than 110, which is associated with the dangerous signs, like everyone should know, that is the headache. So I again repeat, what are the dangerous signs of preeclampsia? One is the headache, then blurring of vision, then there is a epigastric pain, then there is a oliguria. These are the dangerous signs of preeclampsia. When patient with preeclampsia present with these signs, it is very dangerous. Then one other characteristics of the severe preeclampsia is the thrombocytopenia, less than 1 lakh count. Then baby, if the preeclampsia mother has the baby of IUGR, we can say it is a severe. when there is a elevated serum creatinine level or serum transaminase level. These are the also characteristics of the severe preeclampsia. When there is a pulmonary edema and obviously the eclampsia. Okay, all these are the characteristics of the severe preeclampsia. When the preeclampsia occurred in the early age group, you can say it is a severe type of the preeclampsia. Okay. Sorry. Okay, pathophysiology we discuss. There is a severe systemic vasospasm. Then there is an endothelial cell damage. Okay, and there is an increasing the pressure response. Okay, so these points is very important to remember the complications. These points is very important to remember the complications of the preeclampsia. Right? Systemic vasospasm, and every vessels is going to under the spasm, and there is a damage of the endothelium, inner lining of the vessels. Okay, what happens when there is a damage to the endothelium? The intravascular, there is a connection between the extravascular and intravascular. That is, hello? Okay, hello? Okay. So there is a shifting of intravascular fluid to the extravascular space. Because of this damage to the endothelial lining, this work as a barrier in between the vessels, which work as a barrier. And there is a shifting of the fluid from intravascular space to the extravascular space. So because of this shifting in the extravascular space, it present as a edema. Okay, and intravascular, there is a shifting of the fluid, so there is a dehydration of the intravascular, right? So, and already explained the increasing the pressure response or the response to the vasoconstrictive prostaglandins like, hello? Hello? Okay. So the different prostaglandins which is responsible for the vasoconstriction. Okay, we'll see. So the complications. Okay, complications we divide into immediate complications and remote. Immediate, maternal and fetal and remote. Okay. So the in obstetrics, in gynecology, always complications or anywhere we divide the complication immediate and remote. And immediate again we are going to divide into maternal as well as fetal complications. Okay, maternal complications. Just think logically. What I said, it is a multi-system disorder which involves the every part of the body, every organ of the body. Start to think from the head. Start thinking from the head and just think what can be the complication occurs because of the increasing the blood pressure. In the head, there is a brain. The brain, what happened to the brain? There is a hemorrhage, and most important for us is the eclampsia. Okay, there is a convulsion. When the preeclampsia patient has a convulsion, that is called the eclampsia. So the brain related complication related to the brain are the eclampsia, hemorrhage, cerebral edema. Okay, then there is eyes. What are the complications? There is a retinal detachment. Okay, then comes to the down. Then there is a lung, pulmonary edema. Then there is a heart. What can happen in preeclampsia to the heart? Okay, preeclampsia means increase in the blood pressure. When blood pressure is raised, okay, there is a systemic resistance which results into the increasing the cardiac output, or cardiac output has to work against the systemic resistance, and there is a decrease in the preload, because which results into the left ventricular failure. So what are the complications of the heart is the left ventricular failure or sometimes cardiac arrest. What are the complications because of the preeclampsia into the chest? One is the pulmonary edema, second one is the cardiac arrest, and there is the cardiac failure, left ventricular cardiac failure. Okay, then come to the abdomen, liver. You know, the liver, there is a epigastric pain. We already, epigastric pain is the dangerous sign. Why there is this epigastric pain occurred into the preeclampsia? This pain is because there is a hemorrhagic gastritis. There is a hemorrhagic gastritis occurs. So the one complication is the hemorrhagic gastritis. And in liver, there are the important complications. Most important is the HELLP syndrome. HELP. We'll look we'll come to that point. HELP syndrome. Then there is a subcapsular hematoma. Subcapsular hematoma, which can give rise to this pain. Then there is what is the most important organ for us into the abdomen? Obviously, uterus. Okay, there are the n number of complications occurs in the preeclampsia. I mean the gravid uterus. Okay, because of this, there is a uteroplacental insufficiency, and baby present with IUGR. Okay, baby, there is a IUD, intrauterine death. Okay, there can be oligohydramnios. Right. And what happened to the placenta? Because of this raised blood pressure, severe vasospasm, placenta can get separated from its normal position, and that is called as abruptio placentae. That is called as abruptio placentae. Okay. These patients are known for the postpartum hemorrhage also. These patients are also known for the postpartum hemorrhage. Okay, these are all the complications are related to the uterus. Then one important organ is the kidney. So that these patients can present as acute renal failure. Acute renal failure. Okay, so this can be the complications. One more point is remaining, which includes the complication, hematological complications, coagulation disorders. Okay, which is very common in the preeclampsia patient. One by one, again, we just have a revision. Complications, we are going to divide immediate and remote. Immediate means maternal complications as well as fetal complications. Okay, then maternal complications. Okay, so the important is the eclampsia. You have a separate lecture for the eclampsia. You can have a long question on the eclampsia. So that this is the important eclampsia. Then cerebral hemorrhage, and then there is a cerebral edema. Okay, one more complication mentioned into the book is the posterior reversible encephalopathy syndrome. Okay, why there is a edema into the brain because of this? Because why there is a eclampsia or there is a convulsions? Okay, there are the two theories. One, because of the severe vasospasm, there is a vasospasm of the vessels, so that there will be no blood flow to the brain, less blood flow to the brain, so that there is a less oxygen supply, and that causes anoxia, and that can give the convulsion. This is one theory. Second theory, we know that there is an endothelium damage. Because of this damage, there is a leakage of the fluid from the intravascular space to the extravascular space or to the brain part, and which results into the cerebral edema, and that give rise to the convulsions. And there can be the dysarrhythmia, like in EEG, and that can give rise to the eclampsia. So the important one is that this is a 4. Then occipital blindness. Because of this all edema, there can be occipital blindness which occurs into the severe preeclampsia patient, and that is reversible. That is a vasogenic edema. Other name for this blindness is a amaurosis. Okay, so the which blindness occur into this patient, preeclampsia patient, it can be asked into the oral. That is occipital blindness. Then in books it is mentioned in the purchase retinopathy. That is lesions or infections into the retinal. That is a sporadic, and this is a reversible. Okay, this damage is a reversible. Then there is a retinal detachment, which is a mostly unilateral, temporary, and again this is a reversible. Okay, so and there is a one point again mentioned into the book is that is the retinal artery occlusion. Because of this vasospasm, if there is a retinal artery occlusion, and if there is a blindness because of this artery occlusion, that is a permanent damage. Okay, so what are the reasons for the permanent blindness in the severe preeclampsia patient is the retinal artery occlusion. Okay, I repeat: eclampsia, cerebral hemorrhage, cerebral edema, posterior irreversible encephalopathy syndrome, occipital blindness, purchase retinopathy, serous retinal detachment, and retinal artery occlusion. This is all related to the head. Okay. Next one is just a few lines, important lines for the eclampsia. When preeclampsia complicated by convulsions or coma, what is also important. When preeclampsia is complicated by convulsion or coma, that is called as eclampsia. Okay, the causes we discussed, that is anoxia, cerebral edema, and cerebral dysarrhythmia. You have a separate lecture on this topic. Okay. Then other complications. One is the pulmonary edema. In chest, because of the endothelium damage, there is a leakage of the fluid. The fluid directly comes into the alveoli of the lung, and that gives rise to the pulmonary edema. Then left ventricular failure. Reason is systemic vascular resistance, and there is a heart had to works against this resistance, and that is the reason for the failure. One reason is the cardiac arrest. Then periportal hemorrhagic necrosis also is given for the liver. Periportal hemorrhagic necrosis, liver subcapsular hemorrhage. Okay, this is the reason there is a patient can present with epigastric pain. And important is the HELLP syndrome. We'll come to that point. Then again important one is the hemorrhagic gastritis. We discuss it. Okay. So then in kidney there is acute tubular necrosis, that is acute renal failure. Then glomerular endolithiasis. This can be the reversible or very micro level changes occurs in the kidney. Then important point is the maternal thrombocytopenia. This is also one complications. And coagulation disorder, DIC, disseminated intravascular coagulation. This can happen into this patient. Okay, why there is a why this happens? Because there is a reduced level of this protein C, protein S, antithrombin level, which is required for these coagulations. Then we discussed there is a hemoconcentration. Hemoconcentration. Why there is hemoconcentration? Because endothelium damage. Hello. Because of this endothelium damage, there is a leakage of the fluid from intravascular space to the extravascular space. Okay. Sorry. 1 minute. Okay. So which results into the intravascular, hemoconcentration, and which results into intravascular dehydration. Other point is the extravascular overhydration. What are the components of preeclampsia? SMCQ, hemoconcentration, intravascular dehydration, extravascular overhydrations, which results into the edema. Okay. Then what can be the remote complications? Remote complications can be the residual hypertension and recurrent preeclampsia. 50% of the patients of the preeclampsia has a hypertension in their latter part of the life. Okay, 50%. And recurrent preeclampsia, there are the chances, 25% of the chances patient can have a pregnancy-induced hypertension in next pregnancy. Okay, so the two complications: remote residual hypertension, the patient remained as a hypertensive in 50% cases, and second one is the recurrent hypertension, which occurs in 25% of the cases. This is important part. Uteroplacental insufficiency, because this patient has a uteroplacent insufficiency. This is a complications. Okay, uteroplacental insufficiency means uterine artery also occluded and placental artery, umbilical artery also occluded, and which hampers the blood supply to the baby. What happened because of this insufficiency? There is an infarct into the placental blade. There is an abruption. There can be obviously the growth of the baby is hampered. Okay, intrauterine growth restriction. Then there is an oligohydramnios. Then intrauterine death and postpartum hemorrhage. Just read one more time. There is an infarction into the placental bed, abruption, oligohydramnios, intrauterine growth restriction, intrauterine death, and postpartum hemorrhage. So this can be the viva question. What are the fetal complications into the severe preeclampsia? Okay, you should say oligohydramnios, IUGR, then intrauterine death, and postpartum hemorrhage. Okay. What are the placental complications? Abruptio placentae, infarction of the bed. What are the complications occurring into the liver? HELLP syndrome and the subcapsular hematoma. See, this is very common question asked into the exam. What are the dangerous signs of preeclampsia? Dangerous sign of preeclampsia. First one is the headache, that is related to the edema or vasospasm of the vessel supplying to the brain. Then second one is the blurring of vision. Blurring of vision, that is because of retinal detachment or some changes into the blood supply to the eyes. Then third one is the epigastric pain. Obviously, just we discussed, that is because of hemorrhagic gastritis or subcapsular hematoma. Okay, periportal hematoma. Okay, this one. Periportal hemorrhagic necrosis or liver subcapsular hemorrhage. Okay, so this gives the epigastric pain. Why there is a oliguria? Because there is a spasm of the renal vessels, less blood supply to the renal, and less urine output. That is also one of the presentation for the as a severe sign of the the preeclampsia. Okay, next important point is the HELLP syndrome. Okay, you can have a short note on the HELLP syndrome. Okay, this can be covered into the eclampsia also. Okay, so just have a we'll revise it. HELP. So that this is a mnemonic. H for the hemolysis, EL for the elevated liver enzyme. Okay. Then there is the ELP, low platelet count. What is HELP syndrome? It can be asked as an exam. Just give the what are the components of the HELP syndrome. One is the hemolysis. Second one is the elevated liver enzymes. Third one is the low platelet count. So these patients mostly, this can occur in severe preeclampsia patient. This can occur patient with chronic hypertension. This can occur patient with gestational hypertension. When this, and mostly this patient presentation is having some blood pressure with nausea, vomiting, then right cotton pain, go for these investigations. In this patient, there are the chances of parenchymal necrosis of the liver, sometimes subcapsular hematoma, or sometimes very rarely there is a rupture of the liver also. Okay, so this always associated with low platelet count, that is less than 1 lakh. That is less than 1 lakh. This is MCQ. Okay, and elevated AST and ALT. This is the enzymes of the liver enzyme. Okay, there is a sudden raise into this in these parameters presents with patient with HELLP syndrome, and this is a complication of the severe preeclampsia also, right? So what is the management? Management are the same as the severe preeclampsia. We'll discuss this. Okay. Okay. Just remember one point. This definition. What is the acute fulminant preeclampsia? This can be asked into the exam. It is a clinical entity where the onset of preeclampsia manifestation is acute. Okay, onset as a preeclampsia is also acute, occurring de novo. Okay, occurring de novo, or there is a rapid deterioration of an established case of the preeclampsia over a short period of time. That means on the short period, patient can, a normotensive patient present with a preeclamptic patient, or when a preeclamptic patient present with the rapid deterioration, then it is called as the acute fulminant preeclampsia. We can call it as the acute fulminant preeclampsia. Okay, just remember this word. Okay, just we'll come to the now the management part. Management part of the severe preeclampsia. Okay. So the management part is very important. In exam, it is asked in the sort of example. Okay, example like how will you manage patient with primary weight like this, the 28 weeks pregnancy, and blood pressure is 150 by 100 millimeter of mercury, like this. There can be the questions. Okay, so just remember the important lines. Okay, we are going to discuss the important lines in the management of the patient with preeclampsia. So this can be asked in the Viva. What is the definitive treatment of preeclampsia? The answer is the termination of the pregnancy. जब तक pregnancy है, तब तक preeclampsia रहेगा ही रहेगा. The definitive treatment of the preeclampsia is termination of pregnancy. We know the why there is a, this is a pregnancy and there is a raised blood pressure during this pregnancy, and the reason for this pregnancy is the trophoblastic invasion. Reason for this raised blood pressure is the abnormal trophoblastic invasion. Means this preeclampsia is because of the placenta. जब तक placenta deliver नहीं होता तब तक there is a preeclampsia. Ultimate treatment or definitive treatment क्या है? अपने termination of the pregnancy. Okay, but what is the problem occurred if this blood pressures occurred or started in the earlier part of the pregnancy? Okay, when the baby is not mature, That time the management differs. When the patient is a full term like 38 weeks and which has a severe preeclampsia, the management differs. Okay. So this is a balance between all the objectives. We'll discuss it. So if the patients of the preeclampsia comes, the which should include what is the component of her treatment. Okay, we'll discuss first. Okay, what are the component? Okay, can you just message me what are the component? What should be the component? Okay. I seems it is very difficult. Okay. So the important component of the treatment is the rest. Rest is the base treatment. It is said rest is the base treatment for any sort of any pathology into the pregnancy. What happened in rest? We ask patient to the rest on the left lateral position. Because of this position, the pressure of the gravid uterus or the vena cava relieves. So the pressure relieves. So which decreases the cardiac output, decreases the venous return and decreases the cardiac output. So which helps to decrease the blood pressure. Second important point is rest is the which catecholamines decreases the secretion of the catecholamines, and that also helps to improve the blood pressure. So the rest is a very important part of the treatment. Second one is the diet. Okay, in the pregnancy, just in preeclampsia, what happened? There is endothelium damage in the renal vessels. Also, there is endothelium damage, and there is a loss of the protein into the urine. So the diet should include protein diet. Diet should include the proteins, at least 100 gram per day. At least 100 gram per day. So the diet should it reach into the proteins. Okay. One point. And second point, everyone knows hypertensive patients should have a low salt in the diet. Low salty diet. Okay. So the diet protein diet, and there should be less salt into the diet. Okay, one point about the rest. Patient should take rest at least 6 to 8 hours. Okay, at least 6 to 8 hours. We advise in our institute 10 hours rest, 2 hours into the afternoon, and 8 hours into the night. Okay, all patients with preeclampsia we are going to admit. This is an important point. We are going to admit every patient. Okay, we are going to admit all patients of the preeclampsia. Okay, then we monitor the patients, we monitor the blood pressure, we are going to monitor her baby, fetal monitoring. Fetal monitoring can be done with the help of sonography, FHS monitoring, or Doppler monitoring. Okay, so whenever there is a preeclampsia or gestational hypertension or any sort of the hypertension, first we admit this patient, then we make the judgment whether just we'll come to that point. So the admission is an important part of the treatment. 4 points: admission, rest, diet, and antihypertensive drug. Okay. So this is important, antihypertensive drug. So there are the two types of the drugs: first line drugs, second line. There are the n number of drugs, but we discuss the important drugs here only. So the first line drugs, which includes the methyl dopa or labetalol. Nowadays, in our institute, mostly we use the labetalol. Okay. So the methyl dopa is the first. And both are the first line drugs, methyl dopa and labetalol. Exam में यही पूछने वाला है. What are the first line drugs? What are the first line drugs? Or table viva पे भी there is a methyl dopa tablet and there is a vial of the labetalol or the tablet of the labetalol is always there. Okay. This labetalol, methyl dopa, and the second line drug is the nifedipine. Okay. All these drugs are the important. Okay. So when patients comes with the preeclampsia, first we'll advise methyl dopa or labetalol, whoever require the antihypertensive. Okay. The methyl dopa, the dose should be 250 milligram BD. We can start with this low dose, but we can increase up to 1 milligram TDS, means 3 gram per day. Methyl dopa. This is a central acting which has an anti-androgenic action. This is a methyl dopa. It's a centrally acting antihypertensive. Drawback of this methyl dopa is the postural hypertension. Postural hypertension, sometimes headache, sometimes patient present with hypotension. Still, in some institute, most of the uses the methyl-dopa over the labetalol. The second drug in the first line is the labetalol. That is a alpha as well as beta blocker. That is a alpha as well as beta blocker. And starting dose is the 100 milligram TDS, which can be increased up to 800 milligram daily. Which can increase up to 800 milligram daily. Okay, so the second line drug is the nifedipine. Oral dose is a 5 to 10 milligram TDS starting dose for the as an antihypertensive. This is a nifedipine is a it is a calcium channel blocker. Nifedipine is a calcium channel blocker. What is the important side effect? Is a headache, hypotension, vomiting. Okay, so this can be a common question into the exam. When someone asks what is the use of nifedipine, you can say it is as we are going to use as an antihypertensive. The other use into the obstetric is it is used as a tocolytics in preterm labor. यहाँ पे नहीं लिखना है, just ध्यान में रखो. This can be used as a tocolytic drugs. Okay, so this is an important antihypertensive drugs. Okay, now so come to this point. How do you manage when a patient's primary gravida with 32 weeks pregnancy comes with blood pressure 160 by 106? Like this, you have a question into the exam. Define preeclampsia, enumerate the complication of the preeclampsia, and how do you manage when a patient's primary gravida with 32 weeks pregnancy comes with blood pressure 106 by millimeter. What are the other investigation will do these patients? One is the urine. Second one, like the CBC, which includes the hemoglobin. And what is important for us in the CBC? Platelet count, right? We know because if the count is less than 1 lakh, we can say this is a severe preeclampsia, right? Second, yes, paraxylase fetal monitoring. We'll come to that point. Okay. Second point is the platelet count, that is less than 1 lakh. Okay. Then what can we go for the blood investigation? One is CBC, then urine investigation. Blood investigation should include, very nice, Mansi said, liver function test. Very nice. Okay, because we are going to rule out whether it is a type of severe preeclampsia or not. When there is a raised into the liver function test, we label it as a severe preeclampsia. So whenever patient comes with the raised BP, basically we'll do all this investigation: urine, CBC, liver function test. Urine, important point. It should be a dipstick test. Okay, if it is a 1+, then we say it is a preeclampsia. More than 1+, that is a 300 milligram per deciliter into the urine. Okay, so the liver function test is very important. So like this you will have a question into the exam. Okay, so you know the important part of the treatment: rest, diet, antihypertensive. ये तो आपको सब include करना है. Then antihypertensive, which includes the methyl-dopa, labetalol, and nifedipine. Okay. So the management always, this is important point. Management depends upon severity of preeclampsia. Okay, if this patient is not severe, okay, our first aim is to just postpone her pregnancy. Okay, duration of the pregnancy. Then response to the treatment. Okay, and depending on this, we are going to categorize the patients. The preeclamptic features completely subsides. For example, this patient 32 weeks and there is a patient becomes normotency or into the normal range of the blood pressure, and there is no signs of any deteriorations. We'll wait till term. We can wait till term. Then next one is the partial control. With this all treatment and there is no control, completely control over all the preeclamptic features, then we decide to deliver, because we know what is the definitive treatment of the preeclampsia is the delivery of placenta. Okay, but with this we just have a balance, because 32 weeks baby is not so much mature. So in this patient we can give a corticosteroids. Okay, the question is, can you give the corticosteroids in the patient with preeclampsia? Answer is yes, for the maturity of the fetal lung maturity. And third category of the patient is the persistent increasing the blood pressure to severe level. In this category, whatever will be the gestational age, irrespective of the fetal outcome, we are going to terminate the pregnancy. If there is a presence of the complications of the severe preeclampsia or deterioration into the presentations of the preeclampsia, our aim is to terminate the pregnancy, considering the mother's health. Okay, so we'll first think the mother health, and then we'll think about the fetus. Okay, if there is any deterioration at any time, first our management, which should include, is the termination of the pregnancy. Okay, just we'll wind up. If patient is preeclampsia, and now we are decided the delivery by two types, vaginal or by cesarean section. But when urgent termination is required, when there is a complications of the preeclampsia and cervix is not favorable, in that case we'll go for the cesarean. When severe preeclampsia with a tendency to, and if we plan the induction, but the delivery interval increases, in that case also we'll go for the cesarean section. And obviously when there is an associated complicated factor like contracted pelvis and all these things, in that case we'll go for the cesarean section. Three important points you should remember: management during labor. Okay, yes, we can deliver this patient vaginally, but considering all the complications, because when there is during the contraction, intrauterine pressure raises, which leads to the increasing the blood pressure. This is an important point. So because of this, there is a more chances of the eclampsia during the labor. There is a more chances of the abruption during the labor. Okay, this is where blood pressure is tend to rise. So where monitoring should very much proper monitoring of the fetal, monitoring of the mother, monitoring of the all parameters. Okay. Then second one is the labor duration should be curtailed. Okay, you should try to deliver fast. Okay, like surgical induction, like dilatations. Okay, starting of the pitocin will try to deliver the patient fast. Okay, and important point, exam में पूछते हैं, ergometrium is contraindicated in PIH patient. Ergometrium means methagen injection. Okay, which we used after the delivery of the baby to prevent as a part of, after the delivery of the placenta, will give to prevent the PPH, because this methagen causes a vasospasm, and already in preeclampsia there is a vasospasm, so which causes the very cardiac problem. That's why the ergometrium is contraindicated during the labor. ये तीन important point ध्यान में रखो. Okay, Jan, we don't have a time to revise all these things. Okay, thank you very much.